Hello, and you're very welcome to this brief talk on autoregulation of the coronary and cerebral circulations. Please note, this is designed for undergraduate medical students. I can't take responsibility for any clinical decisions that might be made from this. Please feel free to check out other content online. These are the learning objectives of this lecture. Please take time to read them. Autoregulation is a very important concept in physiology, and it's that really of supply meeting demand. And of course it has allowed us to adapt to various environments, and you could say we've evolved with fantastic autoregulation, and that is in some ways why mammals have been so successful. The definition of autoregulation is the regulation of blood flow to an organ over a period of time commensurate with the metabolic activity in the setting of a potentially wide range of perfusion pressures. In other words, we regulate our flow by varying the resistance of the supplying vessels to its own vascular bed. It already comes down to Ohm's law, V over I by R, or pressure over flow by resistance. So what we're saying is that flow is proportional to the pressure gradient, it's inversely proportional to the resistance, and we know the resistance is inversely proportional to the fourth power of the radius. We know this from Poiseuille's law. So the thing we can change most rapidly in the face of changing metabolic needs is the resistance. So how could we control the resistance to an organ, be that the brain or the heart? Well, I tend to use the acronym SLEEP. Now remember, arterioles tend to be meaty and small, they're highly muscular, and they constitute the main resistance vessels. So if we take the acronym SLEEP for a moment, we've got S for sympathetic nervous system vasoconstrictor tone. And we know that we have high basal tone in organs like the skin, bowel, kidney, but tend to be very low in the brain and the heart. We have local factors including hypoxia, hypercarbia, hyperkalemia, acidemia or acidosis, and adenosine. We have endothelial factors including prostaglandins and nitric oxide, which promote vasodilatation, and we have endothelins, which cause vasoconstriction. We have endocrine or circulating hormones, including antidiuretic hormone or vasopressin from the posterior pituitary. We have circulating adrenaline and noradrenaline produced by the adrenal medulla. And we have the renin-angiotensin system, which interacts with the secretion of renin in the kidney. We have paracrine factors, including histamine, bradykinin, and serotonin. Thus, the tone of the arterioles which supply the vascular beds is under many influences, and you can imagine that regulation is very, very complex and has to be able to respond rapidly. The net effect of these agents is to cause increased blood supply or hyperemia. So what we're basically saying is that hyperemia can be active in the form of flow increasing as metabolic activity increases. And of course this is the result of reduced arteriolar resistance. There's another type of hyperemia that occurs, and that's a type of rebound hyperemia when flow is restored following temporary cessation or reduction. For example, if there's a tourniquet applied with reduced arterial flow, if there's ischemia, for example, transient occlusion of a coronary artery causing a heart attack. And finally, a fairly commonly encountered phenomenon called Raynaud's phenomenon, whereby in response to cold there's marked vasoconstriction and a resultant hyperemia as soon as the limb is brought back to normal temperatures. Autoregulation, as we said, is subject to many factors, but other factors that can affect the ability of autoregulation to perform would include age, vascular disease, autonomic neuropathy, for example, people with diabetes, certain drugs, and certain toxins. Let's turn now to the cerebral circulation, and we'll discuss the anatomy initially of the cerebral circulation. There is a certain amount of redundancy within the cerebral circulation. The clinical implication of that is that if one of the blood vessels to the brain becomes blocked or narrowed, that the other blood vessels are more than capable of continuing on bringing sufficient supply. So the circle of Willis, the diagram accompanies the next slide, is relatively straightforward. There's a concept of the supplying blood vessels, which would be the internal jugular arteries, left and right, and the vertebral arteries, left and right. and it's very important that you understand where these arteries arise from. Then you've got the distribution system. You've got anterior, middle, and posterior cerebral arteries, each on the left and on the right. And then to allow these to communicate in effectively a circle, we have anterior and posterior communicating arteries. There are also cerebellar arteries. So this is my diagram of the circle of Willis. These would be the internal carotid arteries, left and right, and these are the vertebral arteries, and these bring blood to the so-called circle of Willis. This is the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. And we have a posterior communicating and an anterior communicating artery. And these are the cerebellar arteries. So as you can see, if one blood vessel becomes occluded, the other vessels are still able to supply the brain. So there's some physiological principles relating to autoregulation of the brain that make it unique. This is the Monroe-Kelly principle. And essentially what it says is that the blood vessels within the brain are inside a hard shell. So you really can't increase the volume of one area without reducing the volume of another. Capillary permeability is different in the brain. We have impermeable capillaries in the blood-brain barrier. Some of the capillaries within the skull are permeable, for example the choroid plexus and the hypothalamus. Essentially, we have an interface between blood and cerebrospinal fluid, and then between cerebrospinal fluid and interstitial fluid, and this is called the blood-brain barrier. We know that the CNS bathes in cerebrospinal fluid, which is a combination of filtration and active transport, and differs significantly from that of plasma. Cerebrospinal fluid and interstitial fluid within the CNS equilibrate freely. So this brings us to how much blood does the brain actually get? In other words, what's normal cerebral blood flow? And here's some figures. At rest, there's approximately 3/4 of a litre per minute of blood going to the brain. This equates to 50 millilitres per minute per 100 grams of brain tissue, or roughly 15% of the cardiac output. Now it's important to note that the brain is very energy hungry. It has a high metabolic rate. 20% of total body consumption is extracted in the brain. Of course, grey matter is more metabolically active than white matter. The result of all of this is that the central nervous system does not tolerate hypoxia. And in cases with insufficient oxygen, cerebral tissue dies very, very quickly because it's so metabolically active. So let's talk a little bit about cerebral perfusion pressure. Cerebral perfusion pressure is a function of mean arterial pressure and cerebral outflow pressure, or venous outflow pressure. In general, cerebral blood pressure is proportional to cerebral perfusion pressure. And of course, cerebral blood pressure is inversely proportional to the resistance. So, what we're going to talk about now is cerebral blood flow autoregulation. And this essentially says that when metabolic demand changes, there is a rapid increase in cerebral blood flow. This essentially means that we can tolerate changes in perfusion pressure by rapid acclimatization of changes in pressure. It also means that if we've increased metabolic demands by the brain, we can increase blood flow. So let's try and tease this out a little bit more. What we're talking about here is flow metabolism coupling. In other words, the cerebral metabolic requirements for oxygen follow cerebral blood flow. So the more we need, the more we get. And in round terms, there's 50 millilitres per minute per 100 grams of brain tissue, corresponding to 3.3 millilitres per minute of requirement for oxygen for cerebral metabolism. And as you can see, there's essentially, in health, a linear relationship. How is this achieved? Well, we talk about autoregulation. What's extraordinary is that with quite a wide range of mean arterial pressure, cerebral blood flow remains constant. So this is where we live within health. We'll say mean arterial pressure of 80 to 130, 120. It's only when mean arterial pressure drops below 60 millimeters of mercury that cerebral blood flow really begins to fall off rapidly. When cerebral blood flow falls off, we get loss of consciousness. Carbon dioxide is a very important regulator of cerebral blood flow. And as you can see here, we live in a very steep part of the curve. This is the normal PaCO2 of approximately 40 millimeters of mercury. Small changes in CO2 have a profound effect on cerebral blood flow. This is actually used clinically in something called therapeutic hyperventilation in patients with brain injuries, where the object of the exercise is to reduce CO2, so there's rapid ventilation used. With rapid ventilation and reduction in CO2, cerebral blood flow is minimized in patients with intracerebral hemorrhage particularly. Oxygen is also an important determinant of cerebral blood flow. We know that the normal PaO2 is somewhere between 80 and 100 millimeters of mercury in health. Over quite a wide range of oxygen partial pressures, cerebral blood flow remains constant. However, once we go below 50 millimeters of mercury, you get a dramatic increase in cerebral blood flow. A clinical correlate of that would be at high altitude, where if the partial pressure of oxygen is significantly reduced, you get a massive increase in cerebral blood flow, and cerebral edema can result. I'd like to briefly discuss with you now the Cushing reflex or the Cushing response. There is a difference between cerebral and other systemic circulations in the way that humoral and autonomic control varies, and there is a very important role of the autonomic nervous system in cases of rising intracranial pressure. So raised intracranial pressure can occur in the context of what's called a space-occupying lesion. In other words, a mass in the brain that's expanding. And as we said earlier, the skull is a rigid structure, so as something enlarges, it has to compress something else. So a typical cause of raised intracranial pressure would be a brain tumour, whether that be primary or secondary, or occasionally if there was a hemorrhage into the brain with bleeding and increase in pressure, and this causes the Cushing reflex. This essentially causes activation of the sympathetic nervous system via the hypothalamus, causing vasoconstriction and an increase in the cardiac output. Essentially, blood pressure will go up and cardiac output goes up. This activates peripheral baroreceptors and causes a reflex bradycardia. So the Cushing response is essentially bradycardia and hypertension in the setting of raised intracranial pressure, and it is a very important clinical sign. It causes clinical signs peripherally because of raised intracranial pressure of papilledema. If it progresses significantly, it can cause brainstem death. So what can cause abnormal cerebral blood flow? Well, obviously, if we occlude a blood vessel in the intracranial course, this can occur with thromboembolic disease or thrombosis in situ. So, for example, if someone had an irregular heartbeat, a condition called atrial fibrillation, and formed a clot within the left atrial appendage, and that travelled to the brain, this could occlude a blood vessel, for example, the middle cerebral artery, and this can cause focal ischemia and typically a stroke. similarly to focal hemorrhage, and I mentioned already space-occupying lesions. The rest of the slide is fairly self-explanatory from the previous slide. A very important response can occur called vasovagal syncope. It's a very common syndrome. It's a type of fainting. Vasovagal syncope is a form of neurocardiogenic syncope. Now, just to define syncope first, syncope is defined as transient loss of consciousness with spontaneous recovery. And there are many causes of syncope, vasovagal syncope being one of them. In the case of vasovagal syncope, because it's mediated by the autonomic nervous system, it's often associated with pallor, sweatiness, a feeling of impending doom, and sometimes people don't totally pass out. Sometimes there's partial loss of consciousness. What happens is that the nucleus tractus solitarius in the brainstem is activated directly or indirectly by triggering stimulus. Now, what could stimulate the nucleus tractus solitarius, which is easier to say NTS, by the way? Well, for example, in somebody who's prone to fainting at the sight of blood activates the nucleus tractus solitarius. On the other hand, in somebody who has postural symptoms, in other words, somebody who's standing for a period of time and gets pooling of blood in their lower limbs, this reduces venous return to the heart. Then the right ventricle contracts while it's empty because venous return, or relatively empty, because venous return has been reduced. And this activates a thing called the Betz-Soliaris reflex, which in turn can activate the nucleus tractus solitarius. But the net effect is that the heart rate slows and peripheral resistance drops. Now, for most people, it's a combination of both cardioinhibitory, in other words, a slow heartbeat, and vasodepressor, which is a drop in sympathetic tone. Some people have predominantly cardioinhibitory, in other words, predominantly a slowing of the heartbeat, and some people have predominantly vasodilatation. The management of vasovagal syncope is generally to avoid precipitants, increase salt and water intake, and explain to the patients that there's nothing sinister going on, so a lot of reassurance. I'll move on now to the coronary circulation. Like the brain, the heart is very energy dependent and very energy hungry, and it has very high metabolic demands. It has a very finely balanced autoregulation. Now, there's no circle of Willis within the heart, but coronary circulation has generous collaterals usually. I haven't drawn the coronary circulation. You should be able to find that in any textbook. But it's important to understand the anatomy of the left and the right coronary arteries. So, the coronary arteries arise from the left and the right coronary cusp, and they fill in diastole. About 5%, or 250 milliliters per minute, of the cardiac output goes to the epicardial vessels to supply the myocardium. There are many physiological and pathological challenges to which the myocardial blood flow is subjected. When we exercise, we need to increase our cardiac output, therefore the myocardium requires more blood. If we develop coronary stenosis and occlusion, we're very dependent on compensatory mechanisms to salvage myocardium. Angina pectoris occurs when supply is exceeded by demand of the epicardial vessels, and as a result anaerobic metabolism occurs, and this causes pain, which is called angina pectoris. We can have angina of effort, which is stable angina. We can have unstable angina, which is arbitrarily defined as new angina, angina at rest, or angina which occurs at reducing levels of activity. If there's a complete occlusion of a vessel, we get infarction, acute myocardial infarction, and a very rare but important concept is that of silent ischemia, in that not every patient will develop symptoms, or at least typical symptoms, or indeed any symptoms, if they move from aerobic to anaerobic metabolism. And silent ischemia is a very important pathophysiological process, particularly in coronary heart disease. So these are the determinants of myocardial oxygen demand. I've listed them out here. We'll start from the bottom. The heart rate will determine myocardial oxygen demand, and we use this in treating people with ischemic heart disease because one of the ways to treat them is to slow the heart rate. Contractility is how vigorously the cardiac cells contract. The more vigorously they contract, the more oxygen they need. Afterload is effectively the resistance or the impedance of the heart as it's ejecting blood. The preload is the stretch on the myocardial cells, and it's related to the end diastolic volume. And then the other factor is the tension which exists on the myocardium, and it's effectively related to the circumference strand of the myocardium. In some ways it could be thought of in terms of the law of Laplace, which is discussed in another lecture. So we have coronary blood flow, and then we have the oxygen carrying capacity of the blood. Now remember, if the hemoglobin is low, for example, if there's anemia, then the oxygen carrying capacity will be reduced. The oxygen desaturation curve is also critically dependent on pH and on 2,3-DPG, and also is affected directly by hypoxemia. All of these factors occur independent of coronary blood flow. In the normal healthy heart, we can increase our myocardial blood flow from 100 cc's per gram of cardiac tissue per minute to 400, so by a factor of 4, but athletes, particularly elite athletes, can do it by a factor of many times more. The reason that we need to increase our coronary blood flow is that even at rest, we extract 75% of the oxygen that passes to the heart. And with exercise, this can rise to 90%, so we're critically dependent on increasing myocardial blood flow if there's increased metabolic demands. A little bit of mathematics of flow in the heart. As we said, coronaries fill in diastole, and we know that heart rate increases at the cost of diastole. In other words, if you look at systole, it remains relatively constant. So the only way you can increase your heart rate is by shortening diastole. Flow relates to the transcoronary or perfusion pressure. In other words, aortic diastolic pressure minus left ventricular end diastolic pressure. So for example, if the patient has poor myocardial function, this means the heart can't empty properly. The heart can't empty properly, then the pressure at the end of diastole will be higher. Therefore, the perfusion pressure to the coronaries will be less. This is often seen in acute myocardial infarction, where there's acute left ventricular dysfunction. Equally importantly, flow is inversely related to the resistance, and the resistance of the coronary arteries is under the effect of metabolic and endothelial mediators and the aforementioned autocrine, paracrine and endocrine hormones, as we spoke about with autoregulation at the beginning of this lecture. It's also related to systolic compression and sympathetic vasoconstrictor tone. This ends my talk on coronary and cerebral circulations. I hope that you enjoyed it, and I hope that you feel free to check out my other talks online. Thank you.